we're sitting down today with Dr. Mike Snyder, our program director for the Colorectal Surgery Fellowship here in Houston. And we want to make a file for our video library. And today I want to talk about rectal prolapse. And Dr. Snyder, just sort of shepherd us through the different treatment modalities that are available, particularly abdominal versus perineal approaches, and how do you choose between which option is best for a patient?
Well, rectal prolapse is a complex problem that involves damage to the internal and external sphincter mechanism by the prolapsing tissue. It is a process that has been ongoing. It's not usually an acute process, although occasionally you can have an acute exacerbation of the prolapse with strangulation or incarceration of the prolapsed tissue outside the body, where it actually can become a surgical emergency. But for the most part, these are fairly chronic problems that have been going on for several weeks before you see the patient. That with the prolapsing tissue that has stretched the sphincter mechanism, these patients may have difficulty with continence. They also may have obstruction in their ability to have bowel movements.
Does that incontinence tend to get better, say, 4 or 5 months after a repair?
About half the time it does, about half the time it doesn't.
Okay.
If the earlier you catch the course of bear it is, the younger the patients are, the better things are. And also the type of operation you do does make a difference. An abdominal operation is the preferred route for young, healthy patients because it has a higher rate of success,
okay.
A lower rate of recurrent prolapse, in the neighborhood of 5 to 8%, depending on the procedure. The procedure that has actually the lowest recurrence rate in most studies is just a simple rectopexy. When you add it with a resection, it does not seem to improve the recurrence rates, and only mildly increases the chance of complications.
Okay, so in your shop, a young person who's physically fit and can undergo an abdominal operation with rectal prolapse, you would offer them a rectopexy without resection?
I would offer them initially a rectopexy with possible resection if they have a markedly redundant segment of sigmoid colon inside their abdomen when we open them up. But for the most part, if they don't have that markedly redundant segment, a rectopexy is more than sufficient.
Okay. And people in the literature talk about Ripstein procedures and many other modalities to sort of to deal with rectal prolapse. Is there any practical value of those, or have you done any of those? Or
I've done about 2 dozen in my career. They are the Ripstein operation is an operation I use for recurrent rectal prolapse after a resection has already been performed. So usually, oftentimes, it's the patient's 3rd operation for the rectal prolapse.
Okay. So what about the perineal rectal sigmoidectomy for?
They are very useful for older patients, patients who a abdominal operation carries significant risks of long-term morbidity and mortality. It is a very safe operation. The amount of pain associated with it is frankly less than a hemorrhoidectomy. When done correctly, it's a 23-hour stay. The rectum and sigmoid colon are usually removed by a perineal approach, by an incision just distal to the dentate line. The full thickness of bowel is then divided, and then the bowel is carefully brought down with division of the mesentery until it can no longer be prolapsed. Special care has to be taken to make sure that the anterior hernia that is always associated with these rectal prolapses is opened to allow and a hernia sac can then be either resected or placed anteriorly to permit adequate mobilization of the colon and the prolapse to be essentially corrected by making sure you remove all the redundant segments. If you do not open up this hernia, there's a pretty significant chance that you'll have recurrence of your prolapse in a fairly quick, early fashion, secondary to not removing enough of the prolapsing segment.
Okay. And when you do these altmeiers, you have sort of the opportunity to do a levatorplasty posteriorly. Is that something you routinely do, or how do you?
I routinely perform a levatorplasty, as you might note from our recent publication in the American Society of Colorectal Surgery journal. Performing a levatorplasty in conjunction with an altmeier procedure does improve both the recurrence rates and lessens the chance of complications.
Okay.
Bleeding is especially decreased with this, as is the very rare but not insignificant chance of perineal sepsis secondary to dehiscence of the suture line.
Okay. And let's say we have, so with the perineal approach, mostly we do an altmeier as you've just described, but what about a Delorme procedure? When do we do that, and what's that about?
Delorme procedure is a procedure where the redundant mucosa is removed with reefing of the muscle there. It performs two functions. The reefing of the muscle decreases the chance of incontinence, and the mucosa prolapse is removed, and then the remaining mucosa is carefully anastomosed to the area just above the dentate line. This provides both a high pressure zone and it fixates the mucosa to this point, so it prevents further prolapse.
Okay.
The recurrence rate for Delorme is about 30%, but it can always be repeated.
Well, say I've got an older patient who's infirm and I'm trying to choose which procedure is best for them. I know I'm going to do a perineal approach. How do I know when to choose an altmeier and when to choose a Delorme? And
if they have full thickness rectal prolapse, especially anything that falls out more than an inch or so, an altmeier is the preferred route.
yeah,
If they have a very short segment rectal prolapse, or frankly just bad mucosal prolapse that's causing mucoid discharge, bleeding, and inability to keep the perineal area clean, then Delorme is probably the preferred route.
Okay. And just one more question. Let's say we've got a patient who's had a recurrence after an altmeier procedure. Can I go from above and do a resection from above, or talk to me about resecting from below when you've resected from above and vice versa?
Well, it's interesting you should say that. You should never perform a resection from above. You've already done one from below because of the concern about leaving a devascularized segment. However, if you're just going to do a rectopexy from above, you can certainly do that. That is a safe procedure from above. As long as you don't divide any blood vessels to the segment in the rectum, you should be fine. However, for people who have had one altmeier, they're usually not great candidates for abdominal surgery. So I would just repeat the altmeier, and frankly, that can be repeated 2 or 3 times, as several of my partners have seen over the years.